My name is Elise McCullough, and I am the host of NeuroSeduction, putting science back into neuroscience. Today, I will be interviewing Arnav Gupta, who is currently working as a medical assistant in the National Spine and Pain Center in Arlington, Virginia. And he has just finished working at the Virginia Hospital Center Emergency Department as a scribe and care manager. And he has graduated from the University of Virginia. So, Mr. Gupta, can you please tell us a little bit about yourself?
Yeah, so as you described, I graduated from the University of Virginia as a Bachelor of Arts in Biology. At my time at UVA, I spent there, I was volunteering at a cancer clinic, and I also did some undergraduate research in actually neuroscience, and we were studying DNA breaks in relation to Alzheimer's and A beta and tau proteins. After I graduated from UVA, like you said, I spent a year at Virginia Hospital Center in the emergency department as a scribe and a care manager. And then after that, I'm currently right now as a medical assistant at National Spine and Pain Centers. It is a pain management clinic. It's a private practice. And there I get to see patients, do scribing, while also getting to see patients and getting their history and helping the doctor in procedures and such. I grew up my entire life in Northern Virginia. I went to school in Virginia, and now I'm working in Virginia. So I'm currently actually applying to medical school, and I'm in the process of doing that right now.
Okay, that sounds amazing. So you were saying you were working at the emergency department, and this was during COVID, correct?
Yes, it was.
So that's actually quite amazing for you to do it during the pandemic itself, being at the front line of healthcare. So what was that experience like?
Yeah, so my senior year of undergrad was cut short, obviously, by COVID, and students weren't allowed to work in the research departments anymore. So I decided I wanted to find another way to help in the community. And I knew as COVID was raging, I thought, hospitals must be burdened right now. And I thought, where else, in society could I make a benefit and impact? And I thought, why not apply to different hospitals and as any position? And luckily I was able to get that scribe in the position in the emergency department. And at first it was a little scary because when I joined in the summer of 2020, we were a few months into COVID. We knew what the symptoms were like, and we knew what to look out for. But every patient we saw, and on the chart we had one bar on the far right side that tracked COVID and whether or not you had COVID and which patients got testing. It was constantly changing regulations and guidelines. When I started, we started first off, we would only do testing on patients that were being admitted or that were going for a procedure or that kind of nature, because a doctor or physician would be closely operating on that patient. Then quickly it changed to, as we got more supplies and COVID came down over time and less people had the virus, and we got more supplies, we got more testing, we decided to test people with all people with symptoms of COVID. But obviously during the times, we had times of shortage, and we would revert back to our old policy of only allowing people getting admission and procedures to get testing. And we were always constantly learning. It was always a learning experience is what I noticed, and constantly trying to use what the scientists and what the government was giving us as information to apply to our policy.
So that sounds quite amazing, but it also sounds very scary if you really think about it. So what really drove you there? Was it did you have a passion for medicine?
Yeah, I've always had a passion for medicine, and growing up, I had a family doctor that I always looked up to, whenever I was sick, my parents were sick, my family was sick, we always went to them for help in times of need and care. And he was always there for us when we needed our we needed help, when we needed aid, we needed to be checked on. Um, and that's something I always liked, being there for somebody, as always being their accountable and reliable person. And in terms of biology, in high school, my freshman year when I started learning about biology, it was just far more interesting than all the other subjects I was learning about. And as I spent time shadowing clinicians and physicians, I noticed that medicine is a practice of teaching, and I love to teach. You can ask my friends, they'll always tell you that I love to teach, I love to talk, and medicine is a practice of teaching and talking. You're trying to teach patients about their body, and the best physicians, as patients will say, are the ones that are able to teach patients about their body and make them understand. And that's really what drew me to medicine. And the reason why I thought that I had to be in medicine during COVID was because, I looked at other physicians. When I was in times of need, they were always there for me. And so why not give back to the community? I knew not everybody can. There are people that are immunocompromised and sick, and that they're forced to stay home, and that's what needed to be done. But as somebody that was young and healthy with a passion in medicine, I thought it was only right if I jumped into the front line.
So I like how you were describing how medicine and you like helping others. That's something I'm really interested in too. So, but what like part of medicine and what kind of medicine are you attracted to, or would you want to go into?
So I'm truly interested in primary care and emergency medicine, as as what I've learned in my long year of time as a scribe. I've learned that medicine shouldn't be, and what I've learned is that you shouldn't seek medicine when you're in a dire situation. I've often seen that that's when medicine, you don't want to be in a hospital when you have to be in the hospital and making medical decisions for your body and your life, when it's kind of like do or die. So I
Yeah.
always think that preventative medicine is the best kind of medicine. And I want to be a primary care physician because that's where it begins. That's where I feel like a patient's experience with medicine starts there, with your yearly physicals and your yearly checkups, monitoring your blood levels, and doing the diagnostic testing that's necessary to foresee what might happen in the future, and then seeing a specialist, being referred to a specialist, so that we see this problem, let's see the specialist now, right? Let's have you refer you to a specialist, so that you see the specialist, they have you on file, they know your case, and then before something happens, they know about you. And I think preventative medicine and primary care in serving your own community is the kind of medicine that I love. I've grown up in Virginia. I've gone to school in Virginia. I lived in the Northern Virginia, DC area. I would love to serve that DC and Northern Virginia area if I potentially could. As a primary care provider would be awesome, serving a local community.
Yeah. So when it comes to the idea of preventive medicine, it seems like a whole different idea, because usually when we think of medicine, we think about someone getting sick and they have to be taken to a hospital or a doctor, and then they finally get the treatment. And
Mhm.
preventive medicine seems so much more patient oriented, and I think that's a cool idea to really think about. And so I've heard that you've been doing research, and especially in neuroscience. And one of my interests is actually dementia and Alzheimer's disease. So if you could explain a little bit about the research you've done, that would be amazing.
Yeah, so the research I was done, if you know a little bit about Alzheimer's disease, we kind of know that it's linked to two proteins that congregate as bundles, the tau protein and the A beta protein, and they clump together. And this clumping together is usually what causes the symptoms of Alzheimer's. And so what my research is to look at mice models and looking at slices of neurons of their brain and tissue of their neurons, and looking at how DNA changes based on different mouse models. So we looked at mouse models with A beta knockout, or tau knockout, and or a genetic variant that was known to clump together the A beta proteins or the tau proteins, so that we kind of had an Alzheimer's disease variant of the mice. And so what my research did is we took these different strains and we took brain slices of the mice with these different um, of these different strains and genetic strains, and we created slices of the brains, and then we created slides of them, and then using those slides we kind of tried to count the using the slides we dyed them with fluorescently tagged antibodies that bound to DNA, binded to DNA breaks, binded to neurons. And then after we did that and we placed the neuron slides into actual slides, the slices into slides, then we could view them under a microscope and visualize and count those DNA breaks using the fluoroscopy.
Okay. So on topic of that, I've heard about this new drug trial that's been coming out, like that's related to like the FDA. And I heard that in one trial that it was working and another trial didn't work. So overall, the treatment of dementia and Alzheimer's disease is very limited as of now. So what do you think is like the future outlook of it? Do you think it'll be cured one day, and how soon do you think it'll be cured?
I don't really, that's a very broad question, and I really wish I could know how long it would take to solve Alzheimer's. I did a very limited amount of research into Alzheimer's that year, and we were looking at a very simple aspect of it, just the double-stranded breaks. I would say we are very far and from the cure, but I know that research is moving on its way, and I do hope one day we would find the cure.
Yeah, I mean, that sounds like probably a reasonable answer. Yes, because everything we've been doing so far is beneficial, but we still haven't made a major first step yet into being able to stop and break down these tau and beta amyloid plaques and still fix the behavioral issues faced by patients with Alzheimer's and with dementia. So let's go a little bit off topic of that. Let's consider something called the opioid crisis. Is there something that you see, and is it a path forward or is it a solution to it?
Yeah, so as my time as a medical assistant at the pain management specialty, we see all kinds of patients, right? So we see patients with chronic back pain, neck pain, shoulder and hip pain, knee pain. It could be from an injury, it could be work related, it could be just chronic over time, your spine, the disc in your spine slip. And our practice, what we do is we do epidural steroid injections, we do nerve blocks, we do trigger point injections, and then we also see patients and prescribe medication for pain management. Our practice, we do a really good job of trying to limit opioid prescriptions, and we definitely we do a good job of monitoring what medications patients are given. And we have patients that are given narcotics. We have, based on the severity of their addiction, we do monthly or every 3 months we test them. We do a urine drug screen to see what drugs that there is in their urine that they've been testing and taking, and just to confirm that they are taking the medications only that we are prescribing. And so it is with the opioid crisis, it is a lot of extra work that healthcare is trying to do right now to prevent it. I also see we have drug representatives that come into the office, and they tell me about how they have created new medications that release the medication that they're coated. The medication is in a pill capsule, and inside that pill capsule, each of there's smaller pill capsules of the medication, and using that increased surface area, they're supposed to decrease the potential of overdose because of, I'm not sure exactly how that medication works, but they're always trying to create new ways to prevent the potential of overdose. And there's so many ways that we do that by first trying muscle relaxers, non-narcotics, doing all of the other things that we can do before we try to prescribe opioids, and we're always trying to track that.
So this opioid crisis, is this a new idea or is it something that's been going on for a long time? And is it going to increase in the near future?
So I definitely don't think it's a new concept to this year. It's something that's been going on for the last 5 to 10 years. In medicine, we found a medicine in opioids that do wonders for pain management. But I have seen in my time in in pain management, about 6 years ago, I used to volunteer at a pain management facility also. And at that time, I was learning about the opioid crisis. And what they were talking to me about back then was that before we used to treat pain as if we want to limit it to 0 out of 10. Before we used to think we need to create a patient with 0 out of 10 pain. We need to get rid of all their pain. But now we're realizing that that's not the way to treat a patient and to handle medicine. The right way to treat and handle a patient and treat medicine is to treat a patient and handle medicine is to limit their pain to a 3 out of 10, maybe a 4 out of 10, to a bearable situation. Say a patient is in their late 70s or in their early 80s, and we're trying to reduce the pain that they're having. We can always have the patient sleep on their bed all day. Maybe their pain won't be there anymore if they're not moving. But what kind of lifestyle is that? Do we want our patients just to be sedentary the entire time? No, that's not what we want. We want them to be able to move around. We don't want them to be moving around and doing the things that they're doing when they're 21 years old. But maybe if we can reduce their pain to a level where they're moving like they can do the things that they're doing in their 60s and their 65s, then that's what we're trying to do.
Yeah. So I from what you're saying, I can understand the pain management is such a big field that not many people consider as a field of like medicine. So, and I liked how you're talking about how opioids is like a more of a last resort type of thing, but you can try to put more methods ahead of it. So speaking of that and how you started a new job at the National Spine and Pain Center, what's an average day there like?
So an average day of life for me is I start the day off setting up the procedure room. I prepare the medications, making sure everything is stocked up, cleaning everything. And then once 8 o'clock arrives, I bring back the first patient, whether it's a new consult or a procedure. When it's a new consult, I'm the first one to see the patient. And so that means I ask the patient their history, what imaging do they have, what therapies have they tried in the past, what medications have they had in the past, how did you find us, how did you come here? Were you referred from a other spine specialist? Were you referred to by your primary care provider? What are you seeking? What therapies have you done? Have you done physical therapy? So I ask them these questions, get their history, and then I go and talk with my provider, Dr. Budampati, and give her that history. After that, me and her both go and see the patient. We offer them therapies, whether it's injections, whether it's pain management through medications, muscle relaxers. We try to create a care plan with them. And then after that, I complete their chart. That's usually writing their history, the impressions, the diagnoses, dictating what imaging they have, their impressions of that imaging, and then discharging the patient that day. And then after that, I usually see procedure patients as well. And during procedures, I bring the patient back to the procedure room. I ask them the questions that are most pertinent, whether or not they're on blood thinners, any allergies, any recent fevers. And then I have them consented. I put them on the exam table. I explain to them again what the procedure is. Some patients have had this procedure multiple times and don't need that explanation. Some patients are very worried. This is their first time having a procedure. They're having a needle being placed oftentimes in the spine, near their lumbar spine or in their back, trying to improve pain. And so I prep their back, clean it, and then I help the provider during the procedure, moving the X-ray into the right place so she knows where to place the needle in the back. using an X-ray machine. So the main types of patients we see that get these procedures are patients with spinal stenosis and radiculopathy, which is radiating pain. A lot of the times, patients that have pain in their legs, or numbness and tingling in their legs, or numbness and tingling in their fingers, or pain in their arms, the pain is oftentimes coming from their spine. As you probably know, all the nerves in our body eventually go to our spine and eventually to our brain. And so we have, as scientists have determined exactly where on the spine all the pain goes to in the body. And so we know what parts of the spine are responsible for pain in the legs. And so after looking at MRIs of the lumbar spine and such, if people are having pain in their legs, we know where in their pain they might have a slipped disc, where they have spinal stenosis, and we try to treat that with epidural shots in the spine that are made to reduce inflammation.
That sounds very, very interesting. So I actually was given an opportunity not so long ago, and I was able to go to a rehab hospital where I got to see patients. I was able to see so many, like about 70 in one day. And then I was able to meet with a doctor and talk about their conditions and how they had like strokes and traumatic brain injuries. And it was very exciting for me. But you will have the same, you do something similar, but you do the same thing every single day. Does that get boring, or is it diverse every single time?
I would say it's diverse every single time. Yes, I'm doing the same procedures, but what makes the job so fun is seeing definitely new consults and reassuring them, and then also seeing the same patients over and over again and having that different conversation about them, getting to bond with them. It's really nice. And when you see a new patient that hasn't gotten this procedure done before, it's always so fun to really reassure them that they're going to be okay. It's not easy going into a procedure room knowing you're going to get a needle stuck in your back. A needle, like some of these needles are 3.5 to 5 to 7 inches long that we're injecting in the back. And being there, explaining to the patient exactly what's going to happen, step by step by step, what you're going to feel, what symptoms are going to happen, reassuring them that everything will hopefully be okay. It's always so nice. And then when you discharge a patient after their procedure and they tell you, you're very kind and very helpful for them, it's really nice.
Yeah. So based on what you said, I can see that communication is such a big aspect of medicine. But there are obviously some other skills and some things that you need to have when you're going into medicine. Is it possible for you to list a couple of them?
Yeah, I would say you definitely have to be humble. You definitely have to be compassionate. You have to also be willing to get your hands dirty when things go wrong, and you have to be like I said, willing to get your hands dirty when things go wrong, but also willing to work long hours and really push through the mental toughness of what it takes to be a physician.
So you just graduated University of Virginia, and now you're waiting to get into the med school. So how difficult was undergrad itself, and how difficult do you think med school will be in comparison?
Well, undergrad was definitely not a breeze. I graduated in 3 years from UVA, and as a biology major, yeah. So my last year, I was taking a lot of biology classes and loading my schedule up, and so it wasn't easy. And I hope it will prepare me for medical school, but I know medical school is not going to be easy, and it's going to be a lot of hard work. But I've been working hard for the last year and a half as a scribe, and now my new position. And I really hope that those two positions my clinical experience is going to serve me well hopefully as a medical student.
So on that topic, what kind of advice would you give students that are in high school and who want to go into medicine? Because I am a senior in high school, and there's certain things that I know, but I think there's a lot more that I could be not exposed to yet.
I would definitely say as a senior in high school, enjoy your time in college once you go to college, and spend times making friends. I would say learn about the local community of the school you go to and try to interact with the local community. And somebody that's going into medicine, I would say medicine is about serving people. And I would
Yeah.
say learn about the issues that face your society and the community that you go to in college, and try to tackle those issues while with your friends and such. And in terms of medicine and the practice of medicine, I would say always surround yourself with medicine. You know, put yourself in positions to be watching providers, watching nurses, you know, learning what it takes to be in a private practice or in a hospital. And you know, you got to start somewhere and be willing to work for free in the beginning and then work your way up.
I mean, that sounds like some really good advice for people who want to be in medicine, especially even when you're a high school senior. All of this could be applicable, and you can learn it then too. So let's move on to a little bit of a more current topic, and let's talk about COVID. So a really big issue right now is like mask mandating, and how certain people want to mask and certain people don't want to. And is there any advice you'd give on that situation and how like we can end this pandemic?
Well, yeah, I mean, I think that not everybody in society is a scientist or somebody that learns about biology. And
Yeah,
as somebody with a foundation in biology, I've always trusted scientists, and I'm hoping that that more Americans trust scientists and the policies that they put out there. And I'm going to continue to do so. And I will say that as a scientific community and a medical community, I think that we need to do also a better job at giving clear guidelines and recommendations, and holding people accountable for the actions that they take. And I hopefully the public will, you know, I would say I think we need to continue wearing masks. We see the variants spreading. Um, we need to continue wearing masks and social distancing. And then once we know that we've gotten over this, then we can hopefully get over it.
okay. So on the topic of that, and you worked at the ER, were there shortages of PPE for you guys?
In the very beginning, we did have shortage of PPE and N95 masks and face shields. So I mean, we tried to test patients with COVID. We thought with symptoms of COVID as much as we could, and we try to limit exposure with patients with COVID. But yes, we did notice some limitations with the PPE. I will say that living in the Northern Virginia area, we are a little bit blessed with healthcare. Our healthcare is one of the best healthcares in the world. So I would say that we didn't face the shortage that I assume other parts of the country definitely did.
Yeah, I definitely agree. COVID is such a scary thing, especially for people who don't have access to PPE or even basic amenities. So I think the more that we can prevent it as a group, the better it is for all of us in the future.
Exactly.
And speaking of the future, do you think COVID's gonna become like a yearly occurrence, or do you think it's gonna something that's gonna die out over the next couple of years?
Well, I'm not sure exactly. I'm obviously hoping that it's going to die out over the next couple of years. But I think that we need to as a society, we need to spend time. I know it's been a long almost 2 years now that we've been dealing with this, but we need to just as a society, we need to all get together and get the vaccine first off. And then, we need to continue wearing masks, and I think eventually we'll get over this. As hopefully it sounds like we'll be needing a third booster shot soon, so we'll see about
Yeah.
that also.
So do you think COVID has changed people like in the mindset of like there's germs everywhere now and that we have to be more careful what we do? And do you think wearing masks will, at least be a little bit more common as in the past? Like when flu was a big part every single year, masks were definitely not common. But do you think that will change when we go a little bit into the future?
I definitely think so. I think, and especially in healthcare, I think I don't think masks in healthcare are going to go away. I've seen photos of healthcare pre-COVID in the emergency department at the hospitals in Northern Virginia. Nobody is wearing masks, and it seemed like in the past, surgical masks were only used for surgery, right? Obviously, you want to see the face of the physician and such like that, but I do see masks in hospitals becoming more and more commonplace for sure, and continuing to stay there.
Well, I think that wraps up a lot of the stuff I wanted to talk to you about. Like, we were able to talk about COVID and research, and even about the opioid crisis, right, that we're facing right now as a country. So I want to thank you again for joining us. And I'd like to give you a round of applause to you, Mr. Arnav Gupta.
Thank you, thank you.
I hope you enjoy working as a medical assistant at the National Spine and Pain Center in Arlington, Virginia. And I wish the best of luck to you.
All right, thank you. It was glad. Thank you for having me.